Hi everyone, this is Neel Raithatha, also known as the Wax Whisperer. Thank you for joining me in my latest video. I have a couple of cases here for you today, and in both patients they had very dry, medially impacted earwax and dead skin, so keratin. And this is patient one. Patient one also had a tender entrance to the ear canal, which had caused them to rub it, and unfortunately it's made it a bit worse. So we had to be really gentle when we're inserting both the endoscope and the instrument into their ear, because we wanted to minimize any contact with the entrance of the ear canal. Usually the outer third of the ear canal, the cartilaginous portion, is our safe areas, made of cartilage. It's flexible, it's got a thick layer of skin acting like a buffer. So it's normally the inner 2/3 of the ear canal that we're mainly concerned about in terms of making contact. But with this patient, we had to also be a bit more cautious than usual in terms of the outer third. So I'm trying to hold the endoscope in such a way where I'm not resting it against the canal wall. And normally that's what we would do. We would stretch the ear open with the endoscope and just place the endoscope against the side of the ear canal to keep it ajar, and also to rest the endoscope so it's nice and stable. Nonetheless, we're managing to remove this. I have referred the patient to their GP because there is a bit of visible inflammation at the entrance of the ear. I've recommended over-the-counter acetic acid spray in the meantime, but they probably need something a bit more stronger that has an anti-inflammatory effect. And there is a particular medication that can be prescribed by the GP in the UK. I'll just come back to that in a moment. You can see there's a little green sequin there. I'm not sure what it is. So this is some debris that's fallen into the ear. A bit of glitter sequin that's just gone in, and it's attached itself to the wax. And that's one of the functions of the wax. Any foreign bodies, particles, debris that may enter the ear that stick to the wax. Obviously there's a foreign object there, and particle that have entered the ear, stick to the wax, and it's protecting the eardrum and also the canal wall. So we've managed to remove the debris from their right ear. So this is the patient's left ear, and in a moment I'm going to circle some cream that the patients tried to apply themselves because of the inflammation, and they've just used a cotton bud, which has unfortunately also pushed this debris further in, but a bit of cream got attached to the dry skin and wax. I'm just going to circle that in a moment so you can see it, well, although it's there on screen, quite visible. So yeah, in the UK, doctors can prescribe a kind of a more stronger version of acetic acid. This medication that they prescribe is called Oadby. It not only contains acetic acid, but it contains neomycin, which is an aminoglycoside. So it's an antibiotic, if you like, and it stops bacteria from reproducing. And in addition, it contains dexamethasone, which is a steroid, which has anti-inflammatory benefits. So that will hopefully help the patient. So you can see the eardrum there. They have got quite a narrow oval shape to it ear. Most of our ears are oval in shape. They're not round, cylindrical, they're more oval, whereby the height of the ear canal is greater than the width, so hence giving it its egg shape, oval shape. I would say this patient's ear canal is slightly more egg-shaped than the norm. Using a fine end suction probe here, and this is the outer diameter is about I'm just trying to remember, about 1.4 mil or thereabouts, and it just about fits at the bottom of the ear canal, so there's not much wriggle room here. I'm just trying to lift this dead skin off the canal wall. Just a bit at the front. So patient's quite happy with that. He's going to have a look at the eardrum, which is slightly dull in appearance. It hasn't got a light reflex, so it's not as glossy and as shiny, but we performed a pressure test and it came back fine. So a pressure test is a test that audiologists use to determine the function of the middle ear. So the middle ear is attached to 3 bones: the hammer bone, the anvil and the stirrup, also known as the malleus, incus and stapes. And the stapes bone, also known as the stirrup, is attached to the organ of hearing, the cochlea. So when sound enters the ear, it travels through the ear canal, it hits the eardrum, that causes the eardrum to vibrate, and these vibrations are transmitted through the 3 bones. So the bones move forwards and backwards like a seesaw, and as the last bone, the stirrup bone, moves backwards and forwards, because it's attached to the organ of hearing, it causes fluid within the organ of hearing, endolymph fluid, to travel in waves. And these waves then travel over microscopic hair cells that are within the organ of hearing, tens and thousands of them. And these hair cells then sear side to side and they contract, and that causes an electrical potential to be generated, also known as an action potential, and that is transferred and transmitted to the brain via the auditory nerve, the eighth cranial nerve, also known as the cochlear vestibular nerve or the audiovestibular nerve. And from the brain, it's processed in the auditory cortex. So that's a pathway of sound. So a tympanometry test, it just assesses the function of the middle ear, how mobile it is. It just makes sure that the bones are fused, not overly fused, because there is a condition where the three ossicles, the three middle ear bones, become fused. It's called otosclerosis. The opposite to that, I'll just explain that in a bit more detail. So if the bones are fused, when the sound hits the eardrum doesn't vibrate. The bones become fixed, so it prevents the eardrum from transmitting the sound waves through the middle ear. And the opposite is ossicular disarticulation, which is also known as ossicular discontinuity. That's when the bones become detached from one another, and the main cause of that is some sort of physical head trauma. And if the bones are no longer connected, they don't move in synchrony, so similarly the sound waves are not transmitted efficiently to the organ of hearing. And in fact, ossicular disarticulation or discontinuity causes the greatest, what we call a conductive hearing loss. If sound can't travel efficiently through the outer ear, which is the ear canal, and the middle ear through the eardrum and the three bones, we call that a conductive hearing loss. Sound's not being conducted through the outer and middle ear. And if you've got ossicular disarticulation or discontinuities, when these bones are no longer connected, that causes the greatest level of conductive hearing loss. If your hearing loss is due to damage to the organ of hearing, the cochlea, so damage to those hair cells I made reference to, and or the hearing nerve, we call that a sensory neural loss. So the sensory aspect of it is the cochlea, because that's the sensory hearing organ, and the neural aspect is the auditory nerve. You can also get another type of hearing loss called central auditory processing disorder, and that's when sounds reach the brain, auditory cortex, but it just can't be processed there, or some way along the auditory brainstem, so up towards the mid-stem of the brain, in the brain itself. So it's more of a central problem. So when you do a hearing test with these individuals and patients, the hearing comes back normal. But when you do a hearing test, we're just assessing your ability to hear simple, pure tones, so single tonal frequencies. And if you've got central auditory processing disorder, it doesn't impact your ability to hear tones. It's a simple sound. Central auditory processing disorder affects more complex sounds, so speech, especially in the presence of background noise. When I'm talking at the moment, my voice contains many different frequencies. I've got the vowel frequencies, which is the lower frequencies, and also the higher frequencies, the consonant, the beginnings and endings of words. And central auditory processing disorder is when your brain receives these different frequencies of sounds contained within speech and background noise in the incorrect order. So it's another term given for it is auditory desynchrony, auditory neuropathy. These things all affect the transmission of sounds to the brain, or the brain's ability to process it. So the best way to describe central auditory processing disorder is if you go to an orchestra and you've got all the different types of instruments being played, and you don't have a conductor, and so all these different instruments are being played but not in synchrony. They're played out of synchrony. So the brain can receive all the sounds, it's hearing all the instruments, but not in the correct order. But once you've got the conductor there controlling when each instrument should be played and what order and what synchrony, that's when things sound more clearer. And if your brain loses the ability to do that, either because it's not processing it properly higher up in the brainstem or in the auditory cortex, or the auditory nerve in some ways not sending those signals through. You can get someone with absolutely normal hearing thresholds, and we do a hearing test, it comes back normal, but we then do a speech and noise test and other tests, to decipher whether they've got a central auditory processing disorder. So hopefully that gives you some information and background about the different types of hearing loss and the causes for it. So patient 2, we've cleared their left ear, as you saw. It's similar to patient 1, very dry earwax and dead skin. Similarly, a bit of a narrow ear canal, but not as narrow as patient 1. I had to use forceps just there just to extract a very dry form of wax. You can see this attaches to the canal wall. You've got skin adhesions here. And I just want to remove as much as possible for the patient. They do wear hearing aids, and they've got their hearing aids where they have domes. So this dome is attached to the end of the hearing aid, the speaker, also known as a receiver. When it's pushed into the ear, it can slightly graze the side of the ear canal wall and push this dead skin off the canal wall. And that dead skin can also block the centre of the dome, and that's where the sound bore is, that's where the sound comes through. So it can cause a reduction in sound for the patient, and sometimes acoustic feedback. When sounds are amplified into the ear by a hearing aid, inevitably some of the sound will escape back out of the ear. And the sound that's already been amplified can re-enter the hearing aid microphone for it to be processed and amplified again. And that cycle continues. So a sound that's already been processed and amplified into the ear escapes, re-enters the microphone, and the hearing aid inadvertently processes it again. So that sound keeps getting processed over and over again. We call that a feedback loop, and it causes the hearing aid to squeal or whistle. So I just want to remove as much debris for the patient to ensure they're getting the optimal level of amplification and minimise the risk of any feedback, because it's one of the things that they do sometimes experience. But of course, we're not going to be able to get every little aspect. We're just trying to peel away as much as we can. Because it's on the cartilaginous portion, the outer third, we can put a bit more pressure, but on the bony parts, we wouldn't be able to do this on the bony part, of truth be told, because it would be uncomfortable. And I'm just here at the border. This is the border between the cartilage and the bone of the ear canal. And that's the patient's eardrum. Well, I hope you enjoyed that video, guys. Take care, keep well, and speak soon. Bye.